everyone.
You sent out the slides, so if we can't get on, we should just go open up those slides?
Yes, please do.
Okay, thanks.
You're welcome.
Okay, so this is Terry. I think we'll go ahead and get started in an effort to try and keep on track. This isn't going to go. Okay, so our agenda, we'll go over welcome and housekeeping real quick. I'll introduce our presenters, and then at the end we've saved time so that we can have questions and answers.
Yep.
Okay. Housekeeping real quick. Please mute your phones. If you don't have a mute button, *6. If there's going to be any background noise where you're at, do not put your phone on hold. When you put your phone on hold, we get to listen to your hold music. With this webinar, we are asking to hold all questions until the end of the webinar, and we have allotted time for you guys to ask questions both of Dr. Srinivasan and of Marc. We also would like for you guys to take a few minutes to complete the evaluation that pops up at the end. And then we thank everybody for joining us. We're excited to have the opportunity to share good information. We have Dr. Arjun Srinivasan from the CDC. He's Associate Director for Healthcare-Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the CDC.
If you guys have any background noise, please mute your phones. Thank you. We also have Marc Meyer. He is a pharmacist and an infection preventionist. He wears both those hats at Southwest Health in Cortez, Colorado. They are going to be speaking on antimicrobial stewardship in resource-challenged settings. And so with that, I'll turn it over to Dr. Srinivasan. Thank you very much for joining us.
Thank you so much, Terry. I really appreciate the opportunity and want to thank all of you for taking time out of very, very busy schedules to be with us today. I'll talk a little bit about some of the national activities, and I'll move fairly quickly because I want to get to the main event, which is Marc's presentation. I think he's really got the meat of how we can work with you guys, and we're very eager to work with you and learn from your experiences here. So let me give a little bit of an update. Let's go to the next slide. I have nothing to disclose. Next slide, please. As all of you know, is reflected by your presence on this call, there are a lot of outstanding benefits antibiotic stewardship programs. There's documented evidence that these programs reduce the complications of antibiotic use, including, importantly, reductions in cases in Clostridium difficile, which has become certainly a very important issue for hospitals now that it's included as part of the pay-for-performance standards from the Center for Medicare and Medicaid Services. We know that antibiotic stewardship programs improve patient outcomes through higher infection cure rates and fewer treatment failures. They can have an impact on reducing antibiotic resistance, and they do all of those wonderful things while saving money at the same time. Next slide, please. These proven benefits have led a number of different groups to call for the implementation of stewardship programs in all hospitals. I show just a couple here. Both the CDC and the American Hospital Association have made formal recommendations to hospitals to implement antibiotic stewardship programs. Next slide, please. How do we do this? Well, I think it's important here to emphasize that hospitals don't all look the same, and you guys know that, of course, which means that stewardship programs won't look the same. And then I think this has been historically one of the great challenges is if you go into the literature and you look at how to staff and run a stewardship program, what you get are the recommendations from some of the professional societies which talk about programs that are present mostly in very large and primarily in academic medical centers where there's a full-time infectious disease doctor and a full-time infectious disease pharmacist and support from microbiology and information technology and all these other groups. And that is an outstanding model. It's been very, very effective in all the settings that are fortunate enough to have those resources. But we also know that most hospitals in America that's not reality for them. Many hospitals don't have infectious disease specialists on staff. Many don't even have access on a regular basis to an infectious specialist. Very few are fortunate enough to have infectious disease pharmacists. The question becomes, how do we implement stewardship programs across the full spectrum of hospitals, including in smaller hospitals that serve, obviously, a very, very important role in our healthcare system? We believe at CDC that there needs to be flexibility in how the programs are implemented, but we know that there are some key elements that have been very strongly associated with successful programs.
Okay.
So what we've done at CDC is, rather than talk specifically about how you staff the program or who needs to be part of it, we have tried to establish the functions that the program needs to accomplish. And we call these the core elements for antibiotic stewardship program. And these are what we've identified as the core elements. And these were taken from reports of successful stewardship implementations and in discussion with a number of different experts on antibiotic stewardship. But these are the fundamental elements. We believe that there needs to be commitment from your facility leadership, from your C-suite, if you will, a commitment to an antibiotic stewardship program. It's very difficult, as many of you know, in healthcare to get anything done without the backing of the administration of the facility. We think there needs to be a single leader that's responsible for the outcomes of the program, but that leader can be any one of a number of different people. We think there needs to be a single pharmacy leader. In some places, that single leader and the pharmacy leader are the same person, and that is a model that can be very effective, and maybe one that is very effective, especially in smaller hospitals. We think there needs to be tracking of antibiotic use. There needs to be reporting of use and resistance back to the clinical community. There needs to be education of providers on use and resistance, and there need to be specific improvement interventions. And so what we try to do is outline, these are the things that make a program successful. How you accomplish these and who accomplishes these will obviously vary from place to place. Next slide, please. I'll talk a little bit about each of these elements. With respect to leadership commitment, we believe that there should be a formal expression of support for the program from the administration. The leadership has to help you ensure that the staff have time in order to implement these programs. We know that financial support helps a lot. It's not always imperative, but it is very, very helpful in implementing effective programs. Next slide, please. We believe that there needs to be a designated leader. What we know is that deferring leadership of a stewardship program to a committee like the Pharmacy and Therapeutics Committee really doesn't work. There needs to be a single person who is on point for actually taking the leadership of this program. We know that physicians have been effective in these roles because prescribing is, of course, a medical staff function, and oftentimes it's helpful for there to be a physician who can help and interact when necessary with prescribers. But we know that pharmacy leadership is also critical with making antibiotic stewardship successful. Next slide, please. We need to track antibiotic use. It's obviously, you can't improve something if you can't measure it. So tracking antibiotic use is very, very important. It helps us find opportunities for improvement, helps us assess the effectiveness of what we're doing. To help with this tracking, we have at CDC developed a program to do that. This is the antibiotic use option of the National Healthcare Safety Network. And this is a fully electronic module that allows for electronic reporting of antibiotic use. And we are working actually and have developed, as you'll hear in just a few minutes, a risk-adjusted benchmark of this antibiotic use data that we will start sharing and helping people use and providing to facilities that are enrolled in the antibiotic use option so that you can compare your antibiotic use to hospitals that are similar to you. Next slide, please. Obviously, reporting and education are critical to anything that we try to do in healthcare where we're working to try and change clinician behavior. Giving information back on antibiotic use, process and outcome measures, Clostridium difficile, reports on resistance. All of these are helpful in helping providers get and stay on board with your efforts. Next slide, please. Ultimately, we know that the real goal here is to embark on specific interventions to improve the use of antibiotics. And so this is obviously a critical aspect of what stewardship programs need to do. Next slide. There are obviously lots of different interventions, and which one you choose to implement and what condition or what drug you might focus on obviously depends on your local needs. Well, this year we did do a survey as part of the NHSN annual facility survey to try to get a sense of how often hospitals were implementing all 7 of these core elements. And this is some preliminary data from that survey, and as you can see, almost half, 42.5% of hospitals in America indicated to us on that survey that they had actually implemented all 7 of the core elements of a stewardship program. Next slide, please. So I think this is an encouraging result. It demonstrates to us that a sizable number of hospitals in the United States have programs that have implemented all or nearly all of the core elements, and that's good. And we know that programs are not limited to these large hospitals. There are smaller hospitals who have found ways to get this done, and that is encouraging to us. But we know that there are still a lot of hospitals, more than half of the hospitals still don't have stewardship programs that meet all of these core elements. And moreover, in looking at the results of this survey, we know that the percentage of smaller hospitals, hospitals less than 50 beds, that have these type of programs is much smaller. So we know that we have a long way to go in supporting the efforts of smaller hospitals in implementing these programs. Next slide, please. Ultimately, if we want to be in a place where every hospital has a stewardship program, we at the national level have to support people in their efforts to do that. And we think there are a number of ways that we can do that. We can provide education and training. We need to help with measurement, both on antibiotic use and on the prevalence of stewardship programs. We need to expand our research efforts, and we need national goals and national policies. And let me say a few words about how we at CEC are working towards these efforts. Next slide, please. Education, we've developed and we've partnered with other groups to develop a number of different educational resources, and just some of those are here. We'll highlight this middle document. It was a very nice publication that was put out by the American Hospital Association in conjunction with a number of different professional organizations. You can see some of the logos there. A toolkit on antimicrobial stewardship that I thought is a very nice resource if you're not familiar with that. That's available on the web, and I think a nice one to take a look at. Next slide, please. With respect to measurement, CEC has been working on developing a risk-adjusted benchmarking measure of antibiotic use. This is a measure that will become part of the NHSN antibiotic use option, and it's our development of this measure really was a reaction to feedback that we've gotten from many, many people who have said we really would like to have a way to compare our antibiotic use to other facilities that look like us to give us a sense of where we might stand. That type of thing has been very helpful in infection control, and people have asked for the same thing with antibiotic use. We have developed a measure, and I'm pleased to let you know that the measure that we developed, which is called the Standardized Antibiotic Administration Ratio, or SAR, was endorsed by the National Quality Forum's Patient Safety Committee in June of 2015. It's now out for public comment before it goes for a vote by NQF membership, and so there will be more to come on that. Hopefully it will be approved this fall, but there is hopefully a measure, a nationally endorsed measure for antibiotic use that is coming. Next slide, please. Both CDC and the Agency for Healthcare Research and Quality have expressed a desire to work to increase support for research efforts in antibiotic stewardship, focused on some very practical questions, I think. What types of interventions are most effective, and how do you implement them? Are there new interventions, and how do we best implement effective programs and interventions in hospitals and other healthcare settings? Next slide, please. Finally, the issue of national goals and policies. Obviously, national goals and policies can be very, very helpful in driving activity and action in an area. And we are lucky now to have some pretty strong national goals and policies put forward with respect to antibiotic resistance. As many of you might know, last fall, the White House announced a national effort to combat antibiotic resistance in bacteria. It's known as the CARB effort. And antibiotic stewardship is described as obviously being one of the critical factors that will go towards supporting this effort to combat resistance. Next slide, please. There were a number of things that were released last September, and one of which is this national strategy, which lays out the approach the government intends to take to combat antibiotic resistance. Next slide, please. And as a key part of that, there are a number of recommendations related to antibiotic stewardship, and let me just highlight a few of these for you here. There's a mention that the government intends to expand and strengthen the national infrastructure for public health surveillance and data reporting, and provide incentives for reporting of antibiotic use and resistance. There's talk about the inclusion of antibiotic use and resistance reporting as part of the hospital inpatient quality reporting program, and an attempt to add electronic reporting of antibiotic use and resistance as an option to meet the requirements of Stage 3 of meaningful use. And those of you who are familiar with the meaningful use program might well have seen that indeed this addition of antibiotic use and reporting to NHSN was included in the proposed rule for Stage 3 that was announced a couple of months ago. Next slide, please. So what are the goals? Well, there are a number of I think pretty ambitious goals that are laid out in this strategy. All states are going to be implementing stewardship activities in healthcare settings. All federal facilities by 2020 will have robust stewardship programs. 95% of hospitals will be reporting antibiotic use data to NHSN, and we will, as a nation, reduce inappropriate use for monitored conditions and agents by 20% in inpatient settings and 50% in outpatient settings, and CDC and AHRQ will expand research. So these are all at a high level, the goals, the 2020 goals for this national effort. Next slide, please. Well, in addition to announcing this strategy, President Obama last September issued an executive order directing certain activities that the government will initiate immediately. Next slide, please. And an important one that I would want to highlight for all of you is this one here, where it says that by the end of calendar year 2016, HHS shall review existing regulations and propose new regulations or other actions that require hospitals and inpatient healthcare delivery facilities to implement robust antibiotic stewardship programs that adhere to best practices, such as those identified by the CDC. And many of you probably know that the conditions of participation for both hospitals and nursing home are undergoing review now. The CMS just this week released the proposed revisions to the nursing home conditions of participation, and indeed antibiotic stewardship is now featured as a condition of participation for nursing homes in that proposed rule, and we are waiting to see what might happen with the hospital proposed rule for conditions of participation. So certainly something to keep your eyes out for. Next slide. Earlier last month, on June 2nd, the White House actually hosted a national forum, which was called the Call to Action for Antibiotic Stewardship. It was a forum on antibiotic stewardship hosted by the White House. Next slide, please. And it was a really unprecedented and an exciting event, at least from the perspective of someone who's spent a career focused on antibiotic stewardship. The White House was able to help us bring together more than 100 different organizations, discuss ways to promote antibiotic stewardship in both human and animal health. And what was interesting about the event was that as part of the event, a number of different groups announced some really important commitments to helping promote stewardship. Next slide, please. And just as an example, there were a number of different health systems that were there, and all of them made strong commitments towards implementing stewardship programs in all their hospitals and working with CDC to start reporting data on antibiotic use. Another example of a really intriguing commitment, Anthem Healthcare, a very, very big insurance company, mentioned that starting next year in 2016, the CDC's core elements for antibiotic stewardship programs will become a part of how they pay hospitals. Next slide, please. So I'm going to wrap up there and say that I think this really is an unprecedented time for antibiotic stewardship. There is a national strategy for advancing stewardship as a key part of combating resistance, but obviously it's easy to sit in an office and write strategy documents. It's much harder to put those strategies into action. And to do that is where we obviously depend on all of you to know how best to do that. And we really want to know how we can work with you, how we can support you, what we can do to help you as you embark on these efforts to execute stewardship programs. And as I mentioned, I'm particularly interested in hearing from and learning from those of you who are in the smaller hospitals, both those of you who have found effective ways to get this done and those of you who are facing barriers and struggles. I'm really eager to figure out how we can help you and support you in these efforts. And I'm going to now turn this over to someone who I consider really to be one of the nation's leading resources on how to get this done in a smaller healthcare setting. I had the privilege of meeting Marc when I came out to Colorado for the kickoff of the stewardship, and frankly was just blown away by the stuff that Marc has been doing and leading at the Southwest Health System there in Colorado. And so I think we're really lucky to have him today as a resource to talk with us about how he has really kind of helped lead efforts to implement very, very effective stewardship efforts and a stewardship program in this healthcare setting. So let me turn it over to you, Marc.
Thanks, Arjun, and thanks for asking me to do this second part of this presentation, and thanks, Terry, to asking me back in October to be part of this collaborative. This is a picture of our little hospital here in the southwest corner of the state. Next slide. So we are a small health system that maybe serves about 50,000 people in rural southwest Colorado. We branch out into parts of Utah. Patients come to us from parts of Utah, Arizona, New Mexico, and we also see Ute Mountain Ute Reservation patients and Navajo Reservation patients at times. We have 25 inpatient beds, and you can see we have probably most of the disciplines that most large heart hospital has. We also have strong outpatient services throughout all those. And our outpatient clinics, we have family practice, OB, GYN, pain management, ortho, walk-in, et cetera, et cetera. So these physicians all work for our system, which can be key as we educate and implement certain things. Next slide, please. So what is stewardship in a critical access hospital? Well, we know, as Arjun said, it does not look the same at every hospital, especially in these smaller institutions where everything's maybe a little bit different. You may not have certain services. You may have different things that other ones don't have. We know that you can have active stewardship programs, so I believe you can, that are going to be very different than the large medical centers, that have an ID doc and an ID pharmacist and, some other programs in place. We also know there's about 1,300 critical access hospitals in the United States, and that accounts for about 80,000 beds. So I think we do have quite an impact on, total health care in the U.S. system. So what does stewardship look like in a critical access hospital? Next slide, please. What I want to do is kind of go over, what I've been asked to do is kind of go over what we do here and maybe give you some ideas. And at the end, I'll talk about, really problems that we have because we are a small hospital, etc. So our stewardship team here is composed of these individuals, and our CEO and CTO, they come intermittently. I think they have a curiosity in what we're doing and an interest in what we're doing. We have 3 physicians currently in this group, and one is the surgeon, and he supported our pharmacy and our infection control program for years, and was a key person in getting some of our e-order systems up as far as pre-op antibiotics. We have our hospitalist. We have a hospital-based program here, and he's been very helpful, and leads the hospitalist group that sees almost the bulk of our patients. A practice physician who's also an OB physician, and we just recently asked an ER physician to join our group, and that's going to be a good addition, I think, as we look at some of the stewardship problems that we see in ERs. We have 3 pharmacists in the facility. All of us participate in the stewardship group, and our director's been here for 30 years. I've been here 26 years. Chris has been here 10. There's not a lot of turnover in our department, and we're all very progressive clinical pharmacists, so that helps a lot. We have a PharmD student most of the year that we utilize heavily. We have a lab representative, usually the microbiologist. The infection preventionist is me. I carry 2 hats. And we recently added a nurse educator. I think that's going to be one of our key factors because she's a young lady who's really good at what she does and helps us getting the education out there to our nurses and our physicians and other staff members. At this participation, I'll discuss why when we talk about problems. So if you core elements that the CD document that CDs puts out, we do, I believe, have leadership support, accountability, infection prevention, drug expertise, and clinical involvement. And I think, go through this presentation, if you look at the core element document that the CDC has provided, you'll see that we cover at least most of those points as we go along. And because of the CHA project, we were able to make our stewardship team actually an official group as a subcommittee of the process in our hospital. Next slide, please. So our pharmacists are probably the key elements in our program. We are very good at drug dose, duration, and de-escalation. And our internists, our hospitalists, obviously provide us with the diagnosis when we work closely with them. We're medication order gatekeepers here, so all the orders come to us for approval. And truthfully, that's where our audit and feedback occurs as we approve the order. And if there's something that we're not happy with about the order, we'll call the physician and we'll find the physician and get it changed at that time. That way we're not waiting, 72 hours and those type of things before we have any feedback. We do adjust dose for renal, liver, and weight. Our IV to PO de-escalation generally probably occurs at discharge because our length of stay is only 3 days. Stop orders, we do have stop orders. Right now it's 5 days. But what happens, that prints out, and we go have usually an in-person discussion with the hospitalist or the surgeon and decide whether we want to change something or go on. We do extended fusion times for our extended spectrum penicillins and our carbapenems, and we usually do a loading dose and then give them over 4 hours the rest of the time. Pharmacists usually take care of that. We have started looking at PPI use and high-risk antibiotics for Clostridium difficile, and the pharmacist is proactive about getting the hospitals to change from a PPI to an H2 blocker. I think there's some out there to suggest that you have a higher risk with PPI use. And we also have been discussing adding a probiotic to our defined high-risk antibiotics and our patients who have Clostridium difficile infections that come to us. And we have chose to use the Kefir product, which has 12 different bacteria in it. And when I was at SHE this year, there was a lot of background discussion about probiotics, and Kefir was mentioned a couple times in the study from England, and that's where we sort of adapted that from. Next slide, please. PharmD students. Well, we have PharmD students about 50 weeks a year, and they're really essential in keeping our stewardship program going. They help with rounding. They do most of our research because they're still students. They're really used to going out, finding the current research. And they're around during the day. They do daily CNS review, and antibiotics timeout truly occurs probably with rounding and the one-on-one with the physician through the students after we discuss things, but not. They like to question. They like to apply what are knowledge. They don't get a lot of stewardship education probably in their university setting, so they really enjoy this, and we do have students 50 weeks a year. And I will say Felicity Burke, who just left us, did a lot. When I talked about Austrian Divicil and some of the things we've done, she did a lot of that work while she's here. And Jennifer Nywan is going to be doing a lot of work on the Kefir and helping us with getting a handbook out. Next slide, please. We do have a closed formulary. Only antibiotics used are those on the formulary. We generally don't add new items unless we take something off. That hasn't been a too big a problem because we haven't had a lot of new antibiotics come out in the last 10 years, really. Not all antibiotics are available to order in the EMR. So a physician many times will have to request them, or the pharmacist will have to recommend them to get certain items that we have. We do have a really strong daily team rounding where all the disciplines that we mentioned that we have here get together at 9:30 every day and talk about all the inpatients. And so we take all of our drug-related problems there, including antibiotics, every day. Next slide, please. We do share data with our area prescribers. Most of them work for the hospital system, so that's fairly easy with email. The other ones, we may hand deliver or take something to them so they know the data that we have going on. Dr. Raynard, like I said, did a lot of work on our surgical prophylaxis e-order set. That's in there for all the surgeons to utilize. We've made sure vancomycin is added to all surgery cases with MRSA positive swab or even an MRSA history. We make sure that's added to in addition to the surgical prophylaxis. We do have different pathways. I mean, CAP and HAP as an example. I mean, your pathways certainly cut down on help with antibiotic usage and help get patients out quicker, which is stewardship. And with the CAH project, we certainly are adding UTI and SSTI to some of our elements that we're really working on. We do also make sure we have empiric coverage for MRSA if they have a history or they're septic. And we have an active antibiogram. And Felicity also recently did some nice pocket cards for our antibiogram. And they're in red and green. And green is for go, which are good antibiotics, sort of. And red is for stop. And it'll be things like clindamycin for us that really doesn't work very well here. Next slide, please. Oh, and since I'm an infection preventionist, I couldn't give this talk without throwing in some IC elements that I think really apply to stewardship. And one of those is hand washing. And being a small facility, we struggled with hand washing. We thought we were really good at it. We had trouble. People would see us coming and then they'd wash your hands. So we added electronic hand washing monitors to all of our inpatient rooms. We use the Permanente system. Not an endorsement, that's just the one we use. And all our nurses and pharmacists and most of our clinical staff wear hand washing monitors all the time. And when we turned it on, it is exactly what you see in the national rates, 40 to 60%. And over the last, half, our hand washing rate overall inside the hospital to over 80%, and many departments are in the high 90%. And that's an actual rate. We have about 1.2 million episodes of hand washing in that time frame. And then for the departments that don't have Proventics, we use ATP testing on their hands everywhere else. And it's a good monitoring because we can swab their hands. We get a reading, it's instantaneous, and if it's greater than 200, we make them wash their hands again. And generally after they do that, it's under 200, and it's a good educational. Actually, we have high school students doing that for us on a weekly basis, very random. We also have an MDRO monitoring program where EMR will flag patients with history of problem pathogens, predominantly those listed in NHSM's module. Plus, we add quinolone-resistant E. coli because we see a lot of quinolone-resistant serum. We don't want somebody put on it if they have a history of it. And we also add ESBL because we do see some of that coming from our nursing home patients. Next slide, please. Also, we have an active CHG bathing program where all of our patients that are admitted in OB, ICU, and Med-Surg all get bathed daily on admission and with CHG bath every day. We use cloths to do that. And we don't isolate for emergency history, only active disease since we started doing that. There was a paper at SHE this year that was from UCLA that pretty much duplicated what we've been doing with this, and their results were pretty good if you saw that paper. We also use MRSA swab and CHG prior to surgery. So our patients come in to do their pre-surgery consult. They get swabbed. We culture that. If it's positive, they'll get MRSA added to their regimen. But everybody gets a CHG cloth to take home with them to use the night of, or the night before, and the morning of surgery before they get the normal surgery prep here. So next slide, please. We also have central line bundles, scrubbers for those central lines, and CHG caps that we use, all cut down on the biofilm growth back up the line. We have VAP and a bundle. We have CAUTI and a bundle in education. We use bladder scans quite frequently. And we look for proven bloodstream infections, culture-based, to try to base our antibiotics on. Next slide, please. For us, we didn't add IT to our group because our Cerner facility, we have Cerner computer system, but we have Cerner Work, which we share with the 18 other hospitals, much like us. And it's hard to get any customization because all 18 have to agree to it. So IT is a little bit difficult for us, so we try to work around that. I would assume that, like us, many critical access hospitals have no report writing support. I know ours, if we want a report that we can't write ourselves, we have to pay significant dollars to get that done. I would suspect that manual extraction might be the case for data. I know in many cases it is for us. And unfortunately, we have, Arjun was talking about total grams and these comparison with the electronic system. Currently, the Cerner Works project doesn't have the ability to pull electronically days of therapy or define daily dose or total grams of antibiotics. So that's kind of something that they really need to work on and fix for us. Next slide, please. And so we've been looking at CDI testing, and what we looked at is all the patients. Felicity actually looked at all the patients that we had in 2015 and 2015 that either got C. diff while they're in the hospital, which wasn't too many, or came to us with C. to be treated. These are the ones that were hospitalized. And when we saw that 60% of those cases came from 2 doctors that are our payroll. So we have limited influence on that. So we really concentrated on the other 40%. And we did find some patients that were admitted or that developed diarrhea after admission that probably didn't have clinical signs of the disease, but just had loose stools. And our nurses are really, in to their credit, are so active trying to stop C. diff from spreading that we tend to draw the test too soon. And so we've developed guidance for this. I think Terry included it with my presentation today of what we decided. We basically want them to have 3 loose stools before we draw a test. And by loose, we want the stool to fit the form of the cup. We don't want it to be hard in any way. In our literature that we pulled showed that we could have people carry the toxin gene in anywhere from spinning wedge paper 2 to 50% of the time. So And I think nationwide we see more C. diff. Some of it could be false positive and non-symptomatic. So that's sort of what we're doing about that. Next slide, please. The other thing, questions I have is for stewardship projects outside the walls of the hospital, especially in these rural areas where everything's kind of seamless into one group, is how do we involve our clinics more in stewardship? That's a question that we want to try to answer. Also, how do we involve other clinics in our area that are not affiliated with the health system here to be good stewards? And how do we involve retail pharmacies? I mean, they see patients maybe getting 3 or 4 courses of an antibiotic or antibiotics from different providers, and how do we get them to catch that and say, hey, something's wrong here, that we're setting this patient up for a CDI. And I'm hoping that the CHA collaborative will be a model maybe to apply to our community, and all of us work together as much as the collaborative has done throughout the state. Next slide. So also, one of the things that I really struggle with is how to incorporate skilled nursing facilities. As we know, in our area, we're seeing some NFs really probably misusing antibiotics by maybe ordering a culture monthly on a patient just to see if they have anything growing where they may not be symptomatic, so they're treating asymptomatic UTIs. And we do see ESBLs and different multi-drug-resistant bacteria from our skilled nursing facilities. We see a lot of quinolone resistance, and probably, I don't have really strong data to support this, but it probably drives a lot of the resistance in our area. So we would like to figure out a way to partner with them and get them not to culture routinely. And I'm really hoping that maybe, though it's not a hospital, CHA can partner with the nursing home group and maybe set up something using collaborative as an example to get something going in that area. Next slide, please. The other problem that we have sometimes is chronic wounds, when to treat, when not to treat with antibiotics. We do have a very good wound specialist here, who's a physical therapist. Her name is Jody, that does a great job with this. But sometimes we still have physicians order antibiotics, probably when neither one of us feel they're really needed. So what we're trying to do is do education on culturing procedures for wounds. We also, I think clinicians feel pressure to order antibiotics to treat sometimes a wound with an antibiotic. And so we're trying to get some guidance maybe for our clinicians so they feel more comfortable not prescribing antibiotic in some of these cases. So we're developing that education right now with our nurse educator, with our PT, and with our lab, myself, and trying to get something that we can hand out to all our clinicians there. Next slide, please. Also, our infusion center that actually is a part of the pharmacy, we have 2 nurses that run that for us. It's a little bit unique, and we have a lot of really rural area here to cover. Some homeless patients, a lot of transient populations, a lot of inadequate to no public transportation for sure. We do have extreme weather in the winter where they can't get here. Travel distances may be up to 60 miles one way. So timing of antibiotics is important. So we're almost forced to use daily dosing and some of the more broader spectrum antibiotics there. So I think one of the questions we've been debating, I know the P&T committee, Dave did add dalbavancin and ortavancin to that. We don't stock those, but we order them as we need them. And we're really looking at research and when we can say we could use maybe that more than, have them come back once a week or 4 or 6 weeks of therapy rather than come in every day, certainly be a benefit for those patients. And so we're looking for, one of the projects I've asked Jennifer to do is see what information we can find on using those on, say, a 6 weeks worth of antibiotic treatment. So, next slide, please. Our antibiogram, and we do have an antibiogram, it's a pretty good antibiogram, but we know that it's IV heavy. So how do we get more PO antibiotic data? That's a question we've been struggling with. We use the Viattac. We recently expanded trying to expand our gram-positive cassette, so there's more PO data. And then again, how do we make it more user-friendly? The pocket cards were one of those things that the clinicians asked for. In fact, it was our outpatient clinic physicians that were asking for it. And how do we get them more data to our inpatient staff? And I would really like to see a local, regional, state antibiogram from the standpoint, I mean, I don't know how we're going to do that, from the standpoint of transfer patients. I mean, I may get a patient back from Denver that was here a couple of days, develops a secondary infection. It'd be really nice to know what their antibiogram is from the hospital that it came from, so we could start that type of antibody care. And the same thing would go for us sending a patient somewhere else. It would be beneficial for them to know what our antibiogram was locally. So, you know, some sort of database we could feed that information to, I think would be very beneficial, at least for, you know, our area, Colorado, where we do have most of the big hospitals along the Front Range, and the rest of the hospitals throughout the state are really small hospitals. Next slide.
Yeah. Why would you put
My final thought would be from the CDC's Get Smart for Healthcare, this slide where they talk about antibiotic overuse contributes to growing problems of Clostridium and difficile infection, antibiotic resistance in healthcare. You know, as Arjun mentioned, Clostridium difficile was named the number one problem bacteria for us. We need to target antibiotic use through stewardship interventions and programs. They improve patient outcomes, reduce antimicrobial resistance, and save money. But I would like to say, under saving money, if you don't think you're going to do all these great stewardship projects and save money, many times you're doing it because it's the right thing to do to get patients out of the hospital quicker, but they don't always save you money. Also, interventions to improve antibiotic selection can be missed in any healthcare setting, from the smallest to largest. So I hope I was able to give you some ideas today. I know we have ideas from ideas from the large hospitals at our meeting in February. And also, improving antibiotic selection is a medication safety and a patient safety issue, so we all should be discussing those in our hospital. So I'll turn it back to Terry and Sarah, and we'll take some questions, I think.
Yeah, thank you so much, both Mark and Arjun. We really appreciate you guys being on the line and giving us your insights, and Mark for sharing your journey and your story at Southwest. So we are going to open it up for questions if anyone has questions for Mark or Arjun, and then we do have a half an hour built in after the webinar is over for those in the collaborative for collaborative questions. So let's keep it just to Mark and Arjun for now. And I'll go ahead and open it. And if you guys are talking in the background, we can hear you, so please mute your phones. Thank you.
Antibiotic. Yeah, we would use it for our inpatients too.
Does anyone have any questions? This is a great time to ask. Mark and
What was that? This question's for Mark. What was that reference for that study you said that was done at UCLA about the MRSA?
It was a paper. If you did your facility go to Shea?
Yes, but somebody did. Yes.
If they go through their abstracts and papers that were presented in the poster sessions, there's a paper from a physician at UCLA that looked at just CHG instead of isolation on their, I believe it was a 50-bed wing. Our original work before, we had CHG and we used his neparacin for 5 days. And after looking at his paper, we thought all along that we could drop the neparacin, and so we've dropped that and just used CHG. And you know, our infection rates continue every year to get lower, and we certainly saw no increase from doing that. So, and that was the REDUCE study, REDUCE. You can look that up. That came out in February or January of 2013, I believe. And if you can't, my email, I think, was on this last slide that I didn't have advanced to. If you email me, I'll try to find it for you again and send it to you.
Okay, thanks.
Hey, Mark, if you want, we can send it out to the group.
That'd be great. I'll make myself a note to find that.
Okay,
Sounds good. We'll do that.
thank you. More
I
questions?
had a question for Arjun. Can you hear me?
Yes.
Yeah, I can hear you.
Yeah. Hey, Arjun, this is Tim Jenkins.
Hey, Tim, how are you?
Good, thanks. Thanks for the talk. To both of
Nice to
you
hear
guys.
your voice.
So I know that a lot of hospitals are very interested in participating in the NHSN antibiotic use module, but there have been some technical difficulties in getting them connected to be able to submit their data. Do you have any updates on the technical aspect of things and kind of connectivity issues and so forth?
Yeah, you're right. So this being an all-electronic module has its advantages and drawbacks, and of course the biggest drawback is that it's all there's a lot of dependency on the IT side of the equation. There are a handful of the pharmacy vendor systems that are able to support reporting. So if you're lucky enough to have one of those, then that's one way. And there are more companies that are moving in that direction. And we have a lot of facilities that are submitting data through what we call kind of homegrown solutions, so they're directly submitting data. So what I would say is, for anyone who's interested, please send me a note, and we are happy to work with you directly. We've got a person here who is really the one who has helped all of the hospitals who are currently submitting data, has helped them all get enrolled, and so she really can walk you through that process. And she's really, really knowledgeable about the different information technology pieces and some of the challenges and potential ways to overcome them. So anyone who's interested, please shoot me a note. We're happy to set up a time to talk, get your IT folks on the phone, get Amy on the phone, who's our person here, talk through to see if we can't help in any way.
Great.
Any other questions? You have about 5 minutes.
I had a bit of a follow-up question for Dr. Srinivasan as well.
Yeah, sure. Please call me Arjun.
With regards to antibiotic monitoring and data collection, are there going to be specific either benchmarks or specific protocols that you guys are going to recommend that every IT department have in the future, such as unit-specific reporting versus whole hospital reporting? Are there going to be very specific parameters that you guys are going to be looking for in the future?
Yeah, absolutely, and thank you for that. It's a good question. The way that the antibiotic use option is constructed, it basically gets all of the antibiotic use data, and then it allows you to view your own data, and you can look at it in a number of different ways. You can look at it by specific locations. You can look at it by types of wards, like medical versus surgical, med-surg, ICU. You can also look at house-wide antibiotics. You can break out locations like the emergency department. And so one of the advantages of getting the data electronically is that once they are in the system, they can be viewed in a number of different ways.
And then for that to happen, I think Dr. Jenkins also mentioned this as well, but I think different hospitals are going to be using different platforms and different IT systems, but are these going to be pretty user-friendly in terms of interfacing, as Dr. Jenkins questioned, or?
Yeah, absolutely. So the way it works is that the data, and this is where the challenge comes, is that the data kind of get packaged on your end into a standard format that's known as clinical document architecture. And so the packaging, it doesn't matter what system is being used. Ultimately, the output has to be a file in this clinical document architecture format, and then that gets submitted into the AU option, and the technical specifications of that file allow the data to be extracted, from any system, put into this common format, and then extracted and then displayed. And so that is the way that those differences in the different platforms and languages and all of those issues get resolved, is through the creation of this package with the clinical document architecture.
Thank you.
Do we have any other questions?
Sarah?
Yes.
This is Charlene Lopez with Skyridge Medical Center.
Hi, Charlene.
And I just had some questions about getting to our data, and maybe I can talk to you.
Yeah,
offline
we
on
have
that.
half an hour built in after this to talk, to ask questions for the collaborative. So we'll have a couple more minutes for Marc and Arjun to answer questions,
perfect.
and then we'll touch base. Any other questions for Marc and Arjun? Marc, this is Sarah. I do have a question for you. What is your, for hospitals that are just starting out with antimicrobial stewardship in a critical access setting, what is your biggest piece of advice? Where should they start?
Well, I think I would do some sort of analysis to really try to identify where your where some of their problem areas are, and then after you get that analysis done, pick a project that and do it well the first time so it's successful, and then the rest of the projects will be much easier. And quite frankly, I think I would utilize the SSTI work that the collaborative's done, especially Tim Jenkins has done, and utilize that form that we've developed and use that as your first project. I mean, that's a great way to start. Or the UETI one that we're about to finalize, that's also going to be a great one to start with. And I think you'll see that you probably do treat asymptomatic UTIs at a time, and so you could work on those. You have the collaborative to support that with getting you data and things that you need to move your group along. So I think that's what I would.
Great, thank you. All right, well, it is 2 o'clock, so in the interest of everybody's time, we will go ahead and wrap up this webinar. Again, we do have 30 minutes set aside for anyone in the collaborative to ask collaborative specific questions about data entry or interventions. So please stick around. Thank you, Marc and Arjun, so much for joining us today on the call. We really appreciate your insights, and we hope you all have a great day. So with that, is anybody going to stick around on the line to ask questions? Does anybody have questions? Charlene, I know you had some questions.
Yes, I do. So we're in the UTI collaborative for Skyridge, but I have still not been able to access that box.
Oh, okay. Okay.
And I know the information that you'd sent prior to that, they were still like the draft copies.
Yep. Okay.
So we haven't, pulled any of our data, and I don't know kind of where everyone is or what the deadlines are. I don't have any of that information.
Charlene, since you are so close to us, maybe we could bring you a flash drive with all of the materials on it. Would that work for you? And we could sit down and talk about it?
Yes, that would be great.
Okay, I'll be in touch with you about scheduling something.
Okay, perfect. Thanks a lot, Sarah.
Sure. Is anyone else still on the line? I didn't know if anyone was going to stick around, so if anyone's there and has questions, we would be happy to answer them.
This is Beth from Newman. I guess I don't know that haven't gotten deep enough in it to know if I have any questions. So I was sticking around to see what questions other people had and what the answers were, I guess, to kind of help me as I take that first step, which I have yet to take.
Sounds good.
Have you tried getting into box.com to see if you can access any of the tools that are in there, or pull up any of the archived webinars yet?
I haven't been able to do that, no ma'am.
Okay. So that's a good first step, and we'd love to schedule time to come out and visit with you too. So I'll be in touch.
Yep, I think we have a phone call tomorrow.
Oh, that's right,
yeah,
we do.
We do.
Perfect. We'll touch base then.
Okay.
All right. Is there anyone else still on the line who has a question?
I am. This is Pharma from Southeast Colorado Hospital, and I'm just getting started, so I have I don't even think I have the information that you sent to everybody else yet.
Okay, Karma, I don't remember that you guys actually enrolled in the project, so maybe we'll have to talk. I know we had talked about it at one point, but
But you know, there's so many different projects anymore, and I'm just reporting to so many different, I don't even know which ones I'm reporting to anymore.
Okay. I will shoot you an email or give you a call, and we'll talk about it.
Okay.
Okay.
Okay, sounds great.
Anyone else have questions about data collection, REDCap, interventions, the algorithm?
I do have one question. This is Mark. When do you, we have a collaborative meeting next week on the UTI, and then you think by the end of that meeting and the next week we'll have the UTI algorithm also?
That's our hope. I'm going to send it out for vetting by our steering committee, hopefully this afternoon. And
Okay.
then we'll address it at our steering committee meeting on Tuesday and kind of see where we're at with it.
Yeah, hopefully by the end of next week, we're thinking that should be ready to go.
Terry, this is Tim. I was just wondering how many sites have actually started to enter data into REDCap yet, and does that process seem to be working okay?
Yeah, so we have gotten a couple questions, and for those of you on the line who are entering data, we have made just a couple changes. I sent out an email to all the data experts from suggestions and questions that we had from you guys, but we've had quite a few facilities start to enter data already and ask questions and get that going. I think we had, the last I checked, we had I think around 75 entries, so we are starting. People are getting going.
Okay.
Yeah, yeah. Is anyone else on the line that maybe has started entering data into REDCap and has any questions, or hasn't started and you have questions about that process? Nope.
Okay.
Quiet group today. I don't know how many people are on the line, but if you guys have any questions come up, feel free to shoot us an email, give us a call. We're always here to help, and we'll get back to you really quickly. Thank you guys so much.
Thank you.
Have a really great day.
Thank you.
Okay,
Bye.
bye.
Bye, guys.
Okay.